So we're going to jump in with Erik Marketan from St. Barnabas Hospital here in the Bronx in New York City. So go ahead, Erik.
Morning, Rob, and good morning, everyone. Rob, I believe you'll be sharing my screen and showing the template.
I think I don't actually have that up. I thought that someone else was going to be doing that. Kathleen, or is anyone else?
Yeah, I've got it.
Let
me try to pull that up right now, Erik.
Great.
Okay.
Thank you, Lawrence.
Cool. You got
it. Great. So good morning, everybody. My name is Erik Marketan. I'm the Trauma Injury Prevention Coordinator at SBH Health System St. Barnabas Hospital. It's a level 2 adult trauma center located in the center of the Bronx. The Bronx is very lucky in that we have 3 adult trauma centers and a pediatric trauma center, fairly evenly distributed. We are in the Belmont section. We're just south of Fordham University. We're very close to the New York Botanic Garden and the Bronx Zoo. And we have a very young, robust immigrant population, in addition to tourists and students from Fordham University. As New York City emerged from the COVID lockdowns in the early summer of 2020, there was a lot of fear of subway and bus travel, which led to a significant increase in the already expanding use of all the micromobile devices that brings us here today. Electric scooters, dock and dockless shared bikes, shared mopeds, et cetera. It's created a lot of confusion for emergency department trauma centers, specific to the trauma teams determining the kinematics of the trauma, whether it be the operator injured, the pedestrian, or the other rider injured in a collision. The American College of Surgeons maintains a trauma registry of all admitted trauma patients, trauma deaths, and transfers. The trauma registrars and the injury prevention coordinators have reported a lot of difficulty with accurate data and pattern analysis due to the variety of the different terms and descriptions that are free typed into the different places in the electronic medical record. It finds itself in the history and physical. We see it in the trauma flow sheet. We see it in the ED comprehensive note, the tertiary note, and sometimes in the consult note. So it's buried, hard to find, and oftentimes variable to the resident attending that's making the note, determining what the device is. So we identified an opportunity for an improved method to allow patients to precisely identify either the micromobile device that they were operating, the device operated when they were struck by another device, and what device struck them as a pedestrian. This resulted in an accurate documentation of trauma registry entry and injury prevention analysis and prevention programming. Bob, can you share the template? Is that on the screen?
I think Lawrence is trying to bring that up. I'm also.
Okay. 1 second. I'm going to share this.
Okay. All right. I'll continue.
The study diagram.
Is it this?
Yes.
Great.
Okay. Fantastic. Great.
Yep.
So the devices were organized into categories of bikes, scooters, motorcycles, boards. You can see essentially we replicated the silhouettes so that these could be shown to patients and pointed to both emergently and non-emergently in our trauma slot or different parts of the emergency department. There's also a desire to have this rolled out and used in a clinic, some of our outpatient areas as well, with respect to prior injuries that occurred not acutely in the emergency department. Each device was assigned a code for data entry, and an example is you have your pedal bicycle is BM1, your electric e-bike is BE2. We made a decision to eliminate branding. We did have a significant uptick in revel injuries, and I think this is something that was occurring citywide, and it was addressed by both policy and the company, and there was a change and a re-rollout. But decisions were made at our facility to be very specific about not identifying specific vendors, but to focus more on the traditional type. And this will sort of impact what we see with the Bronx rollout of the e-scooters, and that there are different vendors that are being placed in the pilot, but we won't be asking and won't be querying as to what specific vendor they chose when they selected to use a shared dockless e-scooter. So back to the template. The copies were laminated and they were placed in the trauma bay, and they're also in a folder, and they're included in the patient record. We've also built this out into the electronic medical record so that we can get accurate and quick documentation, and we wouldn't be losing paper copies that might not get scanned into the trauma flow sheet. We studied this at an intersection about 250 feet from the SBH emergency room. It's a complicated four-way stop, and it includes two curved streets as well as a road that terminates at the bottom of the steep hill. Passenger, car, and truck traffic is slow, and there's no pass-through right of way. So we had an intern utilizing the template, and modes of the transport passing through the intersection were observed and recorded at 3 intervals of 1 hour over 2 days. This was in September of 2020, in the first week. It was a rather warm time. Only 134 devices were recorded during these 3 1-hour intervals over 2 days. 101, 75% were not wearing a helmet, and 25%, about 33, wore a helmet. Electric bikes, manual bikes, and mopeds represented 85% of all devices observed. So your e-bikes were about 30%, your manual bikes were about 30%, and mopeds were about 27%. There was one minor crash of a manual scooter observed during this time period. So we've shown that it's fairly easy for an individual to determine what type of device they were riding from this. And it's easy also for individuals to and clinicians to reconcile that with the template and with the medical record. The design for this, by the way, for myself and how I came from sort of looking at the silhouettes that were designed in World War II for fighter pilots when deciding whether a particular aircraft was a friend or foe. So it's a silhouette that I think conforms uniformly to what that device is. We requested and we received 150 rider helmets from New York City DOT Vision Zero in 4 sizes in late June. The ED helmet distribution initiative, we maintain a par level of 5 in the ED at all times. The micromobile trauma was identified at the physician level. The device was identified based on the template, and helmet use and access to helmets was determined from the patient. If the patient did not own or have a helmet, the DOH helmet was provided to them and recorded at discharge with fit and use instructions. The clinical use of the template in our trauma activations has increased as providers have become more familiar with it, and as we place it more uniformly across our emergency department. We also participate in the New York City Regional Trauma Advisory Committee, which is the RTAC, and we're sharing our template and hoping that other trauma centers join us in a collaboration. We are an adult trauma center, and we do have a pediatric trauma center transfer agreement with NYP Morgan Stanley Children's Hospital, which we've had for a number of years, and it's a very, very successful partnership. And we have heard from them that they are interested in using the template as well, and we're hoping then to get some really rich data from this. We think that with more accurate recording, the study of these largely unregulated and exponentially increasing modes of transportation can be analyzed. And we are currently crafting an IRB, and we're looking at other cofactors for this: injury severity scores, GCS on arrival, trauma activations, AIS, and contributing factors as well: drug and alcohol use and helmet use. So I think
2-minute warning, Eric.
Oh, great, Rob. So, our month-to-month data is showing that there is a lot of need for this template. To give you an example of how busy we are, for our activations between April and May, our trauma codes, which is our highest level of activation, we had 64 codes in April and 75 in May. Our alerts, which is our second tier, 318 in April, 338 in May. So we looked at the trauma division registry data between April and May just to see some seasonal variability. And just from month to month, we saw motorcycle and moped trauma more than double. Our bicycle trauma tripled from 3 to 9. We saw a modest increase in scooter trauma. Again, scooters are difficult because, again, the template is redefining, and our e-bike differentiation needs to be more uniform, and we're working on educating that with the registry. So we're collecting oil on the template, and we have to reconcile that in the registry reporting. Our MVAs were flat. Majority of our MVAs were treat and release, but notably our admissions increased from 1 to 9. There was no change in pedestrian trauma. during this prior 2-month retrospective quick look. And again, the template should really yield a lot more granular data specific to person versus e-bike, person versus moped, et cetera. And lastly, I think a good note for us as a barometer of the sort of temperature of the street, and this is specific to violence in our borough, which has been rather significantly increased. Between April and May this year, our GSWs, our gunshot penetrating trauma, increased from 18 to 31. So we are seeing a lot of individuals on the street, a lot of individuals traveling. And I think that we're hoping that this template will be something that will allow us to do some greater study and analysis. So with that, I conclude, and thank you all for participating.
Great, thanks so much, Eric. Wonderful that we're working together on this.